So to go ahead and begin, I'm going to start off by just giving a little bit of a background. So it's estimated that around 35% of all adults in the United States are classified as having metabolic syndrome. What that means is that they have at least 3 out of the 5 following risk factors. Now, having metabolic syndrome increases the risk of developing type 2 diabetes and/or cardiovascular disease. And this is because metabolic syndrome is associated with decreased metabolic insulin sensitivity, as well as decreased microvascular function. Now, the microvasculature is important as it plays a key role in the delivery of nutrients and metabolites, such as glucose and insulin, to the skeletal muscle. It's also thought to be a key link between the metabolic and vascular systems and may influence fuel selection. Now, in addition to metabolic syndrome, elevated glucose, as seen in prediabetes, is also thought to independently contribute to decreases in microvascular function. Thus, it is reasonable to think that individuals who have both metabolic syndrome and prediabetes may have at a greater risk of decreased microvascular function and blunted responses to insulin. Therefore, the purpose of this project was to determine if prediabetes phenotype exacerbates the effect of metabolic syndrome on microvascular insulin sensitivity. To address this question, we recruited adults between the ages of 40 and 70 years who were classified as having obesity as well as metabolic syndrome. We utilized a 75-gram oral glucose tolerance test to classify individuals based on glucose status of either normal glucose tolerance, impaired fasting glucose, or a combined phenotype that included impaired fasting glucose and impaired glucose tolerance. On a separate day, we had individuals undergo a Euglycemic-Hyperinsulinemic Clamp. This is a 120-minute procedure that involves a constant infusion rate of insulin that is scaled to an individual's body surface area and a variable rate of glucose infusion that is needed to maintain a plasma glucose at 90 milligrams per deciliter. And what this test is able to do is quantify how sensitive the tissue is to that insulin that's being infused. Now, throughout this test, we were then able to assess metabolic insulin sensitivity, which is determined as the average glucose infusion rate over the last 30 minutes of the test. We're also able to take measures before the clamp and towards the end of the clamp, again, to kind of assess the body's response to that insulin. Through doing that, we looked at nutrient utilization, specifically carbohydrate oxidation, as well as the microvascular responses, specifically microvascular perfusion, filling rate, and blood flow. We were able to do this through contrast-enhanced ultrasound, which uses a probe that is placed on the flexor forearm muscles. We infuse activated microbubbles that contain a contrast dye and then create a loop video to assess these measures. Moving on to our results, you can see here that we had a fairly even split amongst the groups, predominantly female and middle age. They were all classified as having obesity. And looking at their overall fitness, we see that based upon ACSM criteria, everyone was considered to be between very poor to poor fitness on average. Although it didn't reach statistical significance, we do see that fasting plasma glucose tended to vary between groups. This was by design based upon having that glucose status and prediabetes phenotype. Finally, moving on to overall glucose infusion rate, remember that's the metabolic insulin sensitivity. We did not see a statistical difference amongst these groups. They were all very similar. And just to note that these values are considered to be lower than in a healthy population. Moving on to our carbohydrate oxidation, we see that at baseline on the left, individuals amongst the phenotypes were very similar. And then in response to that 120-minute insulin infusion, typically we would expect to see an increase in carbohydrate oxidation. However, that was not the case in these individuals. And across all phenotypes, we saw a blunted response. Moving on to microvascular assessments, beginning with overall blood volume. Once again, there was no statistical differences amongst the phenotypes at baseline. And in response to insulin, we would assume to see an increase in these microvascular measures. However, the insulin did not stimulate any capillary perfusion amongst these 3 phenotypes. Moving on to flow velocity, once again, all similar at baseline, and in response to insulin, we did not see any alterations in capillary filling rate. Finally, looking at the microvascular blood flow, which is the product of the previous 2 measures, we again see that at rest, these three phenotypes are similar. And although there appears to visually be an increase, this was not statistically significant. And so once again, insulin did not change capillary blood flow amongst any of these phenotypes. So in conclusion, independent of glucose tolerance, adults with metabolic syndrome have decreased metabolic insulin sensitivity, blunted carbohydrate oxidation response to insulin, and the big takeaway is that they have blunted microvascular responses. And this holds significant implications regarding future risk of type 2 diabetes and cardiovascular disease occurrence. So therefore, future work is needed to examine influences of lifestyle therapies on rescuing this microvascular function to reduce overall cardiometabolic risk. Thank you.